Thank you so much to our healthcare Siemens Healthineers and to Abbott for supporting our 21 ISMICS Reimagined meeting. Really fantastic presentations. On the thoracic tract, we discussed using 3D imaging in the operating room to facilitate thoracic surgery. Sam, what did you think of the cardiac presentations?
I really enjoyed the presentation on Tendyne, Abbas. I think that it's a very versatile technology, and I learned a lot from the presentation. As we all know, calcification in the mitral valve annulus is a big problem, and I think this provides a really good minimally invasive solution. So I learned a lot from it.
Really great presentations. We're going to waste no time moving into our next sessions. Each track will continue on with the master sessions. The cardiac track will go to Cardiac Master Sessions 1B, which is on aortic valve and endovascular, moderated by Dr. Keith Allen and Vinod Thurani. The thoracic tract will go into the Thoracic Master Session 1B, mediastinal disease and the thoracic surgeon, moderated by Dr. Jens Rückert and Dr. Benny Wexler. Thank you.
Take it away.
Okay, great. Thank you very much, Dr. Abbas. I'm Vinod Thurani at the Piedmont Heart Institute, and I would like to welcome you to the Cardiac Master Session 1B, Aortic Valve and Endovascular. We have a session planned for you over the next hour. I'm here with a good friend and colleague. We're just separated by a couple of states, but that's okay. It's Dr. Keith Allen of St. Luke's Mid-America Heart Institute in Kansas City, and who will be co-moderating the session with me. Keith, do you want to tell the viewers what we have in store for them for the next hour?
Great, thank you. We've got an exciting hour coming up here, and what we're going to start off with is here European, U.S., and Asian perspective on U.S. surgical valve compared to TAVR. We'll have a little bit of a discussion after that, followed by 2 live-in-the-box cases and some abstracts with discussions to follow.
Yeah, that's great. Thanks, Keith. We have a lot of ground to cover. Please know that we encourage your participation. This is really important. Please use the Q&A window to the right of your screen to ask your questions as we go along. Now, time to hear from our expert panel. Dr. Ramlawi, why don't we go ahead and get started with you? You're from the Lung Canal Hospital in Philadelphia, PA. Tell us about, in 2 minutes, effective in low-risk patients who are looking for aortic stenosis management.
Great, thank you, Vino and Keith, for the invite. It's a pleasure to represent the U.S. perspective. There's no doubt that TAVR is well established as an excellent therapy, especially for high risk and extreme risk patients. But when it comes to intermediate and low risk patients, it's I think there's a large role to play for TAVR in this particular subgroup of patients. Clearly, in the U.S., there is, from a surgical perspective, there's a CMS mandated national coverage decision for the surgeon and the cardiologist to be part of it. So that clearly plays a different role in the U.S. perspective. But a lot of it is based on local preferences in terms of, and the local center's expertise and the surgeon's expertise specifically, and how well versed they are in the TAVR perspective, and to be able to argue for or against TAVR in that perspective. So, there's a lot of patients that come in with, in their 60s or early 70s that, are very low risk, and those patients should be offered, the full gamut of options for them in isolated aortic valve replacement, whether it's a minimally invasive aortic valve replacement or TAVR, as the case may be. So when it comes to the U.S. perspective, I think a lot of variety comes in, because clearly we're protected from a surgical perspective.
Ja, beim Zimmer. Ja, super, danke, klasse, danke. Ja.
We're protected from a U.S. perspective with regards to the CMS coverage, and that your surgeon has to have a role at the table, and there aren't cardiology-driven versus surgery-driven programs. But in that case, the surgeon, if they're involved, and ultimately, I think we have the best ability to argue for or against TAVR. And you're talking to somebody who has I spend at least half my time in the hybrid room and the other half doing minimally invasive valve procedures. So I think there's a lot of sway and in terms of planning for the long-term future of that patient who is younger and healthier, and how they're going to do with regards to a valve-in-valve option, if that is a good option. I think a lot of the decision-making have to do with the presence of concomitant disease and the presence of technical challenges for TAVR. You know, if the patient's coronary sinuses are smaller, extensive calcification in the LVOT, all these predisposing factors to a suboptimal TAVR outcome is going to be a major deciding factor, as well as concomitant disease. You're not going to ignore healthy, coronary disease in these patients, or concomitant AFib or mitral issues, or certainly in bicuspid valve patients, aneurysm problems. So these are all things that have to do with the long-term planning and not just the immediate short-term planning. And I think that's a lot of it, what we're looking at in terms of how we manage low-risk patients in the US. And that's going to continue an evolving debate at the local level, and how well we as surgeons are able to offer the full gamut, and how we're able to be well-versed in the benefits and disadvantages of all therapies.
Thanks, Dr. Romali. I can already hear the technical problems with my dog in the background, and I apologize. We're going to hear from Tommy Walter from Frankfurt.
Hello, thanks for giving me the chance to present some ideas on European or German perspective. I agree with Basel in many points, and fortunately in Germany we have a legislative rule that surgeons and cardiologists should be part during TAVI, during heart team discussion, etc. But let me step back first. TAVI is a great procedure for the right patient. First, we have to define what is low risk. And this can be based on age, on comorbidities, on anatomy. And I believe age is a weak factor. In some cases, yes, older than 80, straight TAVI cases. Comorbidities is sometimes, this can be very sick patients, and they go for TAVI. But anatomy, morphology of the aortic stenosis, that's the decisive factor in younger, low-risk patients. Let's talk about the 60-year young patient who comes to your outpatient practice. And he says, "Doctor, I've heard about TAVI and it's so easy. I'm home 2 days later and it's great." But you need to convince him that depending on the morphology, he's better off with a resection of that calcium and a safely implanted surgical valve. Then of course he could get a TAVI as a second valve-in-valve procedure in 10 or 15 years in case of degeneration. So we need success factors. We need to define them for the patient that we obtain good outcomes. We want a very low pacer rate. We want a very low paravalvular leak rate. We want to be able to access the coronary arteries, especially in younger patients. They want to exercise, etc. So this is important to discuss with the patients. However, even in Germany, sometimes we get situations that the patient is referred by a cardiologist and it's clearly written, patient denies surgery, he only wants TAVI. He hasn't spoken to a surgeon. How can he decide? But there's sometimes quite subjective decision or influenced by the cardiologist who may believe that TAVI is their field. So we need to be strong, active in TAVI to show that TAVI is our field as well. And then, of course, there are some industry interests, I have to say. You see some advertisements of patients who are 50 or something probably, and who look how great are they looking after TAVI. I don't know whether these are true patients or models. And so it's suggested to patients even that this is such a straightforward therapy. It's important to have a frank, open discussion in the heart team and to put the patient's interest at first. And the best is to have a good heart team where you have kind of a joint budget. You decide together what's best for the patient. The patient with heavy calcification needs resection of this disease burden and then gets safely implanted any surgical prosthesis, and he can get a TAVI in the second step in case he needs it later. So we need to find a good solution for life. And what's important, what's written in the guidelines, but what can be changed sometimes, I believe, very much in specialized centers. So patients should be sent to specialized centers. Best would be if the heart team at the specialized center can discuss everything with the patient, but in real practice, many patients have the ideas already. So it's not so easy for us, but we have to make our points very clear. And these points, the major point is the morphology of the disease. The earlier in life a patient suffers aortic stenosis, the more heavy the calcification usually is. That's my experience. It can be unicuspid or bicuspid valves, eccentric calcification with higher pacer risk, etc. So these patients are better off with a small incision, conventional surgery. Thank you very much.
Thanks, Tommy. That was great overview. Dr. Asai will be the next speaker, and just give us a little bit of the Asian perspective. We're going to get into some of the anatomical stuff later. Just tell us a little bit more about the Asian component. Dr. Toru Asai, well known to ISMICS at the Juntuno University Hospital in Tokyo. I think you're on mute, Toru.
A great honor to be here, to be invited. Before going into the first slide, there is tremendous diversity in Asian countries, as you know. China, Japan, Korea, and Indonesia, Vietnam. I really cannot summarize. So, for example, I just mostly speak about the Japanese situation. My first slide, please. Can you share? Can you see my slide, everybody?
Yeah, we can see your slide, Toru.
Okay. So our practice, and Japanese practice of TAVR started 2014, actually. Reimbursement started. And yearly, it's increasing the number. And let me just speak about some special situation in Japan. We do have a very strict control by a committee of Japanese transcatheter valve treatment, actually therapy. This committee strictly controls the number of Japan performing TAVR. They provide proctoring, education, and initial newly developed. And also the accreditation is strictly limited. Can you go, another aspect, our insurance system. In Japan, universal health coverage. This is covering most of even a very expensive TAVR procedure, mostly cover. So patients don't have to pay too much. They do pay some, but they don't have to pay big expense for the TAVR procedure. On the other hand, the other many Asian countries adopt mixed medical treatment, part of which is covered by public health insurance and the rest without such insurance, so they pay. For example, the China, rich people get a rich valve, but poor people cannot get. In Japan, we have the most successful communist system in Japan, ironically. Okay, so but I think cost of TAVR and TAVR probably the same to the other country, but we do have probably 10,000 US dollar for, and TAVR valve is actually 45,000 US dollars. Next. Another aspect is the longevity difference. Japanese people live longer. We have 81 in men, women 87 in 2019 data. The China is currently catching up to the US. But that means if you put the valve, TAVR valve, SAVR valve in early age in a low-risk patient, that the durability of each bioprosthesis may really important. Next. Also, physical constitution. Japanese man is very small, even smaller than American women in terms of BSA. The size of annulus prosthesis may matter, maybe change, maybe different in terms. Next, please. This is most important slide of my presentation. That's it was shocking for myself. That's all Japan data from a certain bioprosthetic major company. That's all percentage of implanted bioprosthesis, surgically implanted bioprosthesis several years back. As you see, less than 21 or equal to 21. It's almost 70% dominance. Can you just click? So as you see, less than 23, you cannot get any efficient valve in SAVR procedure. So 70% of patient is not really getting sufficient valve in SAVR. But in our practice, with meticulous decalcification, calcium peeling off, and also adopting low aortotomy, can you click again? This is our own practice. Can you click again? Keep clicking. So, the same Japanese patient, I think meticulous difference. So if we continue to perform mediocre procedure of surgical AVR, we cannot expect survival of patient as well as survival of surgical AVR in the future. Thank you for your attention.
Great, thank you so much, Dr. Ramalawi, Walter, and Asai for your global perspectives on this. And clearly, it's very different across the globe. I can tell you that in the United States for 2020, and from the TVT database, 29% of patients who underwent TAVR in the United States, 29% were low risk, 30% and then the other 71% were equally split between intermediate and high risk. So in the United States, a third, and a third. Low risk, medium risk, high risk. So the bar has changed. We only have a couple of minutes for discussion now because we're a little over, but Tommy, go ahead.
I found this last slide from Toru extremely interesting, and congratulations on your achievements of implanting larger valves. And this brings me to the point, we need to do a good job. My former chief, Fred Moore, in the 90s, he once said a 19 valve is too small for patients. Maybe for Japanese it's not, but for European patients. And in the end, we need to think about modifying techniques, even some annular enlargement techniques that are around that can be easily performed by skilled surgeons. But aortic valve surgery is not enough to send the patient home with a very small valve, because then the cardiologists directly say, when you guys implant such small valves, we do TAVI straight away, and you're not doing a good job. So we need to do a perfect job. That's very important in the younger patients.
100% agree with you. So, Basil, this question is for you. Are surgeons crybabies? Are we whining about TAVR because we haven't gotten involved? And most of the surgeons sit in the control room, and right before the valves actually deploy, they come in, they don't even know how to get access. Are we being crybabies? I mean, are we whining over this when we haven't done our part to be involved?
I completely agree with you. Vino, we go around, and I'm sure you do as well. And I go around, and many of us on the panel here do go, and we see this in proctoring and teaching these, that, a lot of the surgeons in most centers, I would not say all, but many centers are not as vested in the TAVI procedure as they need to be. Give them the authority to argue for or against that procedure. And I think once you get to know how to do TAVI, then you can really say when you cannot do TAVI and when it's been suboptimal for TAVR. And many of those patients, we as a valve specialist need to evolve within cardiac surgery, that we're focused on the valve procedure. And you're going to have valve specialists, you're going to have coronary specialists, you're going to have heart failure specialists. And the ones that do valves, will focus on the whole spectrum of valve, including TAVI, minimally invasive. I have a lot of patients, just like you mentioned earlier, about that get referred who are 65-year-old that want to go golfing and they don't want an open surgical procedure and they will not accept a sternotomy. They want a TAVI procedure. That's what they've been sold on. But when you start talking to them about minimally invasive option, for example, or right anterior thoracotomy, where they're going to go home in 3 days or so, and they are much more willing to accept that, and that is a much more easier sell. And especially if you provide the larger annular valves that Dr. Asai mentioned earlier, that's definitely something that we need to do. So we need to learn how to do improved surgery through less invasive, larger valve implantation. And then we need to know TAVI and when not to do TAVI and be able to argue for it. So I completely agree with you. We need to do better as a valve, as a surgeon.
So maybe Tommy and then Keith, and then or maybe we'll go Tommy and then Dr. Asai, and then Keith will wrap it up.
I found this point extremely interesting or important that you said we need to be dedicated in the TAVI room as surgeons. The problem is very typical, at least here in Germany. You have a OR schedule for the next day, and the complex cases are being done by the experienced surgeons. So some younger guys remain, and when there's a TAVI day, then they are sent to the TAVI. On the other hand, cardiology is sending the most experienced guys who are the interventional cardiologists, head of the cath labs, to TAVI. So we have a mismatch. Yeah. We need to define a dedicated person who's the TAVI expert, but who is a surgeon.
So Tommy, just to give you an idea, we have a senior surgeon on Tuesday that we do TAVRs, and we do 5 to 6 a day. And we have myself goes every Wednesday, and I don't operate that day. And I'll do 6 TAVRs that day on Wednesday without going to the OR. So I think that you can do that. We do that personally here. So Dr. Asai, and then Keith, you want to wrap it up after that? Any comments, Dr. Asai, on how
I was grown up in all the school at NYU in many years ago. So there's all open surgery. I think aortic valve surgery is actually ideal setting for the training and fellow, and it's a tremendous experience to learn myocardial protection and also the setup for the pump. That's that kind of long in the United States. I don't know. But the thing is, I still feel very difficult to teach youngsters for, let's say, 5 centimeter right thoracotomy incision. If you have any, root or some injury or little bleeding, it's really tough to teach and work together. It's compared to the old days. So I think learning curve or the ladder steep is very, very, acute. And how can you take care of this in advanced country like the United States or Germany?
So we'll have Keith do the last comments, and maybe next year, maybe we'll urge the ISMICS directors not to give us just 15 minutes. Keith?
I think we could talk forever on this topic, but just to conclude, surgeons bring a wealth of information to the table because the surgeon's at a unique advantage. If he learns how to do TAVR, he can do both TAVR and surgery. We are going to learn a lot about how these TAVR valves behave in the future, and the surgeon is an ideal person to be on the front end and deciding, what should be the initial procedure, surgery or TAVR. Let's move on now to our next valve in box presentation, and Axel is going to give us a really nice case of valve in valve TAVI with modification of the valve.
And Alex is from the German Heart Center, a pre-recorded video.
Dear colleagues, it's my privilege to say welcome to you in our hybrid OR at the German Heart Center Berlin. We are going to present a TAVI valve procedure to you. So now I would like to hand over to Karol. He's going to present the case to you.
Our patient presented in this case is an 81-year-old female, and she had surgical aortic valve replacement in 2012. And back in that day, she received an Intuity 19mm valve because of a small annulus. Now, at present, she presents with a structural valve prosthesis deterioration with severe aortic stenosis and moderate regurgitation. We may not forget that our patient is quite obese with a BMI of 30 and a BSA of 1.9, suggesting some kind of PPM. Since 2 months after the initial surgery in 2012, she presented already with a mean valvular gradient of 24 millimeters of mercury. Looking at the coronaries, we have no coronary artery disease, no stenosis, so everything looks good. Regarding device landing zones, the inner diameter of the prosthesis was measured to be 16.9 millimeters. And after analysis of our CT reconstructions, we found a safe virtual transcatheter heart valve to coronary ostial distance. Looking at the vascular tree, which gives us some information about calcifications, stenoses, or soft plaques, we opted for the left side for main femoral axis of device deployment. Since we are facing the problem of patient prosthesis mismatch, we opted for the Evolut R valve because of her supravalvular design to hopefully keep transvalvular gradients as low as possible. If we would still find some elevated gradients after valve deployment, we will evaluate on the operating table for balloon fracture. The patient has been informed about the off-label character, but anyway, redo surgery was not a good option in this patient. And now I would like to hand over this case to Axel and Christoph.
Christoph, would you like to comment on our setup?
Usually we do a 3-point access. We decided on the left side to do the valvular implant because the vascular structure is better on the left side.
We have the first signs of degeneration of the prosthesis, and if we check the long axis view of the aortic valve and check the function with a Doppler, what we can see here is a regurgitant jet in LVOT, orifice area 0.97, so something about 1 square centimeters, which is rather low.
Of course, we are facing some kind of PPM in this patient, but I think the main problem is deterioration of the bioprosthesis. The patient did very fine for many years, and a couple months ago, suddenly she became symptomatic. So I would assume that it is more the aspect of deterioration than of existing PPM. And next step is we are going to introduce the TriGuard system for cerebral emboli protection. It's done in bioprojection. Cowboy head.
Cowboy head configuration, yeah.
We are going to place the pre-shaped stiff wire. The specific case we are using an Innovi wire. We have here 14 French delivery system, and in the presence of this narrow iliacofemoral arteries and the stenosis at the common iliac artery, I think this is a good option to cross.
Okay, and I think the commercial alignment is fairly good.
Yeah. The head marker is in a correct orientation, right?
So where are we going to aim for the height of the valve? Where do you want to end up with the frame end?
Yeah, when we look on the Intuity design, the leaflets are mounted inside of the upper part of the stent frame. So I think we should end up with the lowest part of the Evolut inside of the lower stent, so in the middle part of the lower stent.
Yes, we start with pacemaker 140.
So here now we have it
Pulling a little bit, pulling a little bit.
Yeah. Okay, now we are probably where we want to be if the left goes up. You think it's a little low?
Yeah, but it's
occlusive at the moment.
Yeah.
That's the problem with valve in valve, that you do have the occlusion phase.
Face off. I think we should do it like it is.
We should do it like it is?
I would say.
Okay, I think we are a bit low, but I think it's not too bad, so we're going to release the valve now. I mean, it's going to snap down, and hopefully the left coronary side is going to move up, because in the stand it probably can't go down. Yeah, I think it's good.
So our next step is to evaluate what we have achieved.
We can see maximal pressure gradient still 45, mean 21, so like very similar. and but increase of the valve area to 1.2.
But the question is, should we use balloon dilation and possibly fracture?
Very difficult. I mean, she's 81. I think there's good arguments to just leave it like it is and not do anything. On the other side, you know, you want this to be her last valve ever. So to optimize anatomy for better flow through the valve, if there's possibly not a full expansion of the valve, I think that's an argument for balloon dilatation.
Yes. Yeah, I think it's enough. Pacing off. We will measure again our invasive gradients. There's not really a gradient, so it's peak gradient 7 to 9 in the end. No regurg and good perfusion of both coronaries. That's it. Thank you so much.
Okay, thank you very much.
Summarizing the procedure, device success was achieved without PDL and a peak-to-peak gradient of 5. The Evolute prosthesis was deployed in the lower position related to the oblique approach angle. In the post-procedural CT scan, a discontinuity and an enlarged internal diameter of the ring of the intuitive recognized. Redilatation and possible ring fracture as well as the suprarellar design were found to be effective to minimize PPM. The commissures of the Evolute were found to be anatomically aligned, which guarantees an unrestricted access to both coronary arteries. The post-procedural course of the patient was completely uneventful. She was extubated on the table, transferred to the regular hospital floor 3 hours after the procedure and discharged home early. Thank you and best regards.
Axel, that was a great video. We're going to, for the sake of time, continue to move on. And Jan Riker and his team from Poland are going to present a short case in the box, continuing to talk about stretching the limits of TAVR.
Good morning, ladies and gentlemen. My name is Jan Richter. I'm a cardiac surgery resident in Silesian Center for Heart Disease in Poland. Today, I will present to you the following topic: successful transcatheter implantation of self-expandable prosthesis in patients with existing mechanical mitral valve. I have no conflict of interest to declare. This case report presents a 76-year-old woman after mechanical mitral valve replacement and tricuspid valvoplasty 20 years ago. She was admitted to our hospital because of worsening dyspnea. Echocardiography revealed severe aortic stenosis with good function of mechanical beleafed mitral valve, mild tricuspid regurgitation, and moderate pulmonary hypertension. Coronarography showed no significant narrowings in coronary arteries. Due to advanced age, poor mobility, and high Euroscore 2, patient was qualified for TAVI. Computed tomography showed moderate to severe calcification of bicuspid aortic valve type 1, with raphe between right coronary cusp and left coronary cusp. Limited derived annulus was 24.6 mm. Left coronary height was below 8 mm. Right coronary height was 14 mm. Distance between aortic valve plane to mitral mechanical valve ring was 6 mm. In our experience, when the distance is more than 5 mm, it is safe distance to perform TAVI with self-expandable prosthesis. We decide to implant Boston Scientific Accurate Neo and prosthesis. Due to good size and not to femoral arteries, we perform standard transfemoral approach. First step, we put 6 French pigtail in non-coronary sinus and made aortography to check implant view. After checking implant view, we introduced the delivery system and started positioning of the valve. The valve marker should be put at the end of the pigtail. After proper positioning, we start deploying accurate Neo valve. When achieved stable position, we remove the pigtail and deploy the valve. After valve deployment, we observed that the valve fully expanded. We not observed any paravalvular leakage. Post-procedural echocardiography revealed good function of accurate neoprosthesis with mean gradient 7 mm of mercury and no paravalvular leakage. Patient was transferred to the surgical ward for further treatment and rehabilitation. She didn't require blood transfusions. No new conduction disturbances appeared. She was discharged home in overall good conditions 3 days later. Thank you for your attention.
Thank you very much, Dr. Richter. It was a great presentation. Our next presentation will be again presented by Dr. Richter and is titled Successful Transcatheter Treatment of a Deteriorated Sutureless Valve Using Self-Expanding Prosthesis. Dr. Richter, take it away.
Good morning, ladies and gentlemen. My name is Jan Richter. I'm a cardiac surgery resident in Silesian Center for Heart Disease in Poland. Today I will present to you the following topic: successful catheter treatment of deteriorated sutureless valve using self-expandable prosthesis. I have no conflict of interest to declare. This case report presents an 80-year-old woman who in 2010 had received a Libanova perceval M23 mm sutureless valve due to severe aortic valve stenosis. In 5-year echocardiographic follow-up, we see good function of the valve and stable state of the patient. At the end of 2018, she was admitted to our hospital due to worsening dyspnea. Nowadays, echocardiography showed deteriorated prosthesis with severe aortic stenosis in moderate aortic regurgitation. In coronography, there was no significant narrowings. The score 2 for this patient was 30%. The computed tomography showed well-adopted perceval S prosthesis with perimeter derived annulus 90 mm. We use the valve in valve F for choose optimal prosthesis for the patient. We choose the accurate NEO-S. Here you see the simulation of the implantation of this kind of valve into the perceval S prosthesis. Due to the several calcified femoral arteries, we abandoned the transfemoral approach for the transapical approach. After performing the transapical approach, we put 6 French pictet to the non-coronary sinus, make the implant view check, and then put the delivery system through the apex to the aortic valve plane. The accurate neo-valve black marker should be put in the inflow ring of the perceval S prosthesis. We made the rapid pacing for the stable position of the valve. After deployment, we see the non-fully expanded valve and the moderate paravalvular leakage. So we performed the 80 mm balloon post-dilatation. We see that the valve was expanded and the paravalvular leakage decreased to 3 val. We see good function of the valve and 3 val paravalvular leakage. Patient was extubated, transferred to the surgical ward, and there was no new conduction disturbance, and patient was discharged 3 days after the surgery. Thank you for your attention.
Thank you. Great presentation, and congratulations on your team from Poland having 2 papers on it this year's ISMICS. We're going to continue to move on with our theme on stretching the limits of TAVR valves, and we're going to see a case from Dr. Walker in the University of Florida looking at how to treat TR.
Hello, my name is Kristen Walker, and I'm a current CT surgery fellow at the University of Florida. Today, I'm going to be discussing a novel approach to severe symptomatic tricuspid valve insufficiency. I have nothing to disclose. Severe tricuspid regurgitation is usually secondary downstream effects of longstanding LV dysfunction. The link between implantable device leads and the development of significant TER has been confirmed in scale studies. Isolated tricuspid valve repair or replacement is a relatively rare surgical procedure given its high reported mortality and a paucity of data supporting its effects on survival. In light of this, elderly or frail patients with severe TR and a prohibitively high perioperative risk are left with significantly decreased quality of life and few options other than medical management. The no-touch valve technique is presented as a compassionate technique for patients with prohibitive surgical risk and severe TR in the setting of intracardiac leads. The patients described underwent stage procedures replacing the intracardiac leads with microleadless pacemaker within the RV, as well as placement of a SAPIEN 3 transcatheter valve within Cook-Z stents at the inferior cavoatrial junction. Our first patient is a 74-year-old male with severe symptomatic TR that developed after insertion of a permanent pacemaker. He was not a surgical candidate due to frailty and associated heart failure with an EF of 20%. Right IJ and right common femoral vein access was established, and a snare was used to bring a Stork wire from the right IJ out the femoral vein, creating a total body floss. An exchange catheter was used, and an extra stiff Amplatz wire was inserted over which the Cook-Z stents were deployed using a coda balloon as a bolster. Here you see both 35 millimeter stents deployed at the cavoatrial junction. Finally, a SAPIEN 29 SAPIEN 3 valve was deployed within the stents using venography midway through to confirm adequate position. There was some mild reflux into the hepatic veins, which was unavoidable due to the proximity of the cavoatrial junction. This is his postoperative TEE with improvement in the retrograde flow through the IVC. The patient subsequently underwent microleadless pacemaker insertion in a staged fashion and is now reporting NYHA1 symptoms with significantly improved quality of life. Our second patient is an 84-year-old male who presented with progressive NYHA3 symptoms that began after placement of a St. Jude's pacemaker. Initially, his pacemaker and associated leads were replaced with a micro pacemaker. He returned a month later with persistent heart failure symptoms and severe TR. Given his associated comorbidities and frailty, decision was made to pursue palliative CAVI procedure, which was performed as previously described. He too is reporting NYHA1 symptoms with resolution of his ascites and significant improvement in quality of life. Here you can see representative plain films before and after his no-touch tricuspid valve replacement. In summary, we have demonstrated that the no-touch valve technique is feasible and safe palliative procedure for patients with severe symptomatic TR who are not surgical candidates. Thank you for your attention and the opportunity to present today. Are there any questions or comments from the audience?
Okay, great. Thank you so much, Dr. Walker. This is a great presentation. Our next presentation will be a solution to MAC, mitral ring as landing zone for transcatheter mitral valve implantation, to be presented by Nicholas Bonaris from the Innsbruck Medical University in Austria. This will be our last presentation before the group discussion. So Dr. Bonaris, it's all yours.
Welcome, ladies and gentlemen. I'm Nicholas Bonaros from the Medical University of Innsbruck, and I would like to show you a case of a hybrid solution to major annular calcifications in a patient with a severe mitral valve disease. These are my disclosures. This is a 76 years old patient with a previous aortic valve replacement with a single bypass to the RA. Both are working very well. This patient is coming with a severe mitral disease with annular calcifications, which you can appreciate in the CT scan, and a very high degree mitral regurgitation. We performed a simulation with a 3D printing to see the effect of a potential transapical mitral replacement, and we saw that there was a high risk of LVOT obstruction. This was the intraoperative part. We identified the increased mitral calcification. We implanted a 34 millimeter flexible LivaNova Memo 4D ring on the top of the annular calcification on the atrial side. We then we did that to increase the landing zone of the transcatheter valve. Then we resected the anterior mitral leaflet after supporting the subvalvular apparatus in order to decrease the risk of LVOT obstruction after the implantation of the transcatheter valve. We performed the annuloplasty in the conventional way. We used some additional sutures on the two commissures to increase the circular shape of the ring. And then we performed the balloon valve implantation using a 29 millimeter SAPIEN 3 valve, aligning the here the sealing suture of the valve to the annuloplasty ring. You can see a very slow implantation, which allows us a circularity of the flexible ring. We then checked the position of the valve in the annulus, and we tightened the sutures to the two commissures. Filling the left ventricle demonstrated no paravalvular regurgitation and a good opening of the valve without any obstruction of the left ventricular outflow tract. We also checked that there is no paravalvular regurgitation at the commissure sides of the ring, and echocardiography also showed no paravalvular regurgitation with a good opening of the valve with a mean gradient of 2 millimeters mercury. Some points to discuss. We use the flexible V-shaped ring to increase the landing zone for the balloon expandable transcatheter valve. We remove the anterior mitral leaflet to minimize the risk of a VOT obstruction. And we also use an annuloplasty ring to stabilize the annulus and avoid AV dehiscency. We reinforce the commissures with pleated sutures to minimize the risk of paravalvular leakage. I'd like to thank you for your attention, and I'm happy to discuss with you this case. Thank you.
Dr. Benares, for that great presentation. We've got just a few minutes that we can open it up to the audience for questions. You could refer to the Q&A box, type in your questions, and we'll get to them.
So great. So we have just a couple of minutes for a discussion. I want to maybe first start off with, this is for our European, for Axel and also Jan. You presented this any meeting where we've had multiple presentations of rapid deployment valves getting TAVR valve-in-valve. In the United States, we're not doing a ton of rapid deployment valves like you are in Europe. It's a lot more prevalent. Are you starting to see SVD at before 10 years in structural valve deterioration? Presented 2 cases, and there's a Percival under 5 years, and I can't remember, Axel, how long your patient was. Well, what's going on here? Can you explain to us a little bit about the rapid deployment valves, and are you starting to see some SVD within 10 years? And what do you tell these patients? I tell patients 10 to 15 years. Are you telling them something different for rapid deployment valves? So Axel first.
Yeah. Rapid deployment valves have not been used very often at our institution, but has been used especially for patients with small annuli, and I think this is not really a higher incidence of early SVD in these patients, but some of them come back. So I think we did 3 Intuity cases so far in the last 3 years, and yeah, I think it's not more common, and usually the initial hemodynamic is pretty fine with this small rapid deployment valves.
I just want to mention, I'm not sure that the intuitive valve, quite honestly, is crackable because of the chromium cobalt. Keith and I both don't think that is. Keith, am I wrong in saying that?
No, I think that's a good point, that both Percival and Intuitive aren't breakable. And I think maybe a more appropriate title for yours would have been remodeling the valve.
Yeah.
Because you really stretched it, you got a millimeter bigger. And I think that's perfectly fine. But I think it belies the fact that you need to be careful about which surgical valve, whether it's a regular surgical valve or a rapid deployment valve. If you're going to pick a valve, at least pick one down the road that is suitable for valve-in-valve or can be modified to enhance the outcome following valve-in-valve.
Yeah, and remember that's chromium cobalt versus nitinol for the two different valves.
Yes, in our center we don't make a lot of Perceval. From 2011 we made about 50, 60 Perceval valves. And this is our one rapid deployment valve. But in this particular patient, there was no problem in patient prosthesis mismatch because She was BSA was about 1.8. BMI was about 25. So we don't the ppm problem not exists in this patient. We have low gradient before valve implantation. The aortic valve area was about 1.67.
Sure. Keith, you have another question for Dr. Walker?
Yeah, I do have a question for Dr. Walker. We've looked at this technique that you described, and one of the issues we've had is that the IVC at that level is usually quite large. Now, you put a 29 valve in a 35 stent, and I'm just trying to get the sizing. How much volume did you add to the valve? Did you modify it by adding an additional felt skirt? Because our issue has been we just don't have a good TAVR valve, even with adding volume to fit in that location a lot of times.
Kristen?
Yes, we added an extra 4 cc's to the balloon, and we got an adequate seal with that.
So, Kristen, there's a question from the audience in saying that that others have performed cable valves in both the SVC and the IVC, and why did you just choose the IVC? This is from past President Anson Chung.
Yeah, we like the IVC only because we have excellent symptomatic resolution with just using the IVC to simplify the procedure.
Yeah, I mean, I've also worried about continued RV dynamics in patients who get this type of cable treatment. So that'll be very interesting to see. So I think one last question I think that we have, I do want to make a comment. Somebody put on the chat that intuitive valve is chromium cobalt, but the inflow frame is stainless steel. So a correction from us on that. So Andy Campbell, thank you so much for that. And so I think the last question that we'll have for you, Nicholas, goes to you. You know, I've done a lot of the hybrid mitral max where you put a ring there. I've just done exactly what you did, but I didn't put the ring there, and it caused that. Do you think the ring is necessary, or can you just put the stitches like you did and then take the flow of the actual SAPIEN 3 valve?
Oh, absolutely. The main advantage you have with the ring is that you landing zone at the lead. So what you do is to gain some height at the level of the atrium so that you don't delve into the ventricle. So the more you are into the ventricle, the higher is the risk of LVOT obstruction, of course. And this was the thinking about this patient. So this was the background plan. As you saw on the 3D model, we had a very narrow left ventricular outflow tract. So we tried to patient height to the level of the atrium to gain height from that.
Okay, great. Let's move on to the next section. Thank you, everybody did a great job. Thank you so much. Truly a global and international session so far. Our next presentation, we won't disappoint you, will be coming now from Germany again. It's called New Arch Stenting with our Martin Searsney. Martin?
Hi everybody and welcome. It's my pleasure to share with you in the next few minutes a few thoughts about total endovascular aortic arch repair using the Terumo aortic relay branch system. These are my disclosures. This is what we have done in our aortic program last year, and as you can see, more than 120 patients had thoracic aortic pathologies involving the aortic arch, so this becomes a continuously increasing important component of each and every aortic program. Let's start with a few thoughts regarding the underlying pathology. Penetrating atherosclerotic ulceration is a specific form of patients we are treating. And here you can see an aortoscopy of a patient with multiple PAUs during aortic arch replacement using the frozen elephant trunk technique. And how the aorta looks inside can be anticipated by outside, meaning by imaging. And this is something we have to be very clear, because this is the the determination of success or failure by using the respective technique. Another aortoscopy of a patient with aneurysmal formation of the basis on the basis of a chronic aortic dissection after previous type A repair, a very smooth intimal surface, so no remaining risk of embolization here, irrespective of what treatment modality you are choosing. Branched frozen elephant trunk implantation forms the basis of each and every aortic program. And just a few glimpses onto the operation, which usually or very frequently is a redo operation. In our setting, more than 40% of patients have already undergone a aortic replacement. Here you can see the insertion of the prosthesis during hypothermic circulatory arrest and during here the reimplantation of the head and neck vessels, and in many of these patients also the aortic root has to be addressed either by biological aortic root replacement or by valve-sparing root replacement according to the underlying pathology, as can be seen here. And now for something different, namely the same operation by endovascular means. Here a short video regarding the details one has to be aware of when performing this procedure. At the very beginning we will see a CTA of a patient with a large penetrating atherosclerotic ulceration at the distal aortic arch, where subclavian to carotid transposition or even double transposition would not have created a sufficient proximal landing zone for TEVAR, and where total endovascular aortic arch repair is the way to go. This is a modular system with a retrograde delivery of the main body via the femorals. The detail is that the introduction sheath, the introduction system has 25 or 26 French according to the diameter. So excess vessels have to be adequate, and the left subclavian still has to be revascularized with a bypass or by transposition. And then in a second step during the same procedure, the bridging stent grafts are being implanted via both common carotids. Here are the details. The ascending aorta has to be at least 6 centimeters in length to host the proximal component. Here you can see the modular system with the main body, and here you can see the large window hosting the sleeves for the supraortic branches, where then the bridging stent grafts are connected. The introduction sheath has a so-called self-aligning mechanism, which means that the window hosting the sleeves for the supraortic branches orientates itself automatically towards the outer curvature of the aortic arch, which then enables exact deployment during the procedure. So the setting is pretty much comparable to our TAVI setting. So the tip of the stiff guide wire is located at the tip of the left ventricle. We do use rapid pacing for blood pressure lowering. Here you can see the setting. The main body is being advanced. The technical detail is that the proximal portion has to be as deep in the ascending as possible to have a very smooth angulation between the window hosting the sleeves for the supraortic branches as well as the native supraortic branches. The system has a tip capture which enables perfect stability during deployment of the main body, as you can see here. And after release of the tip and deployment of the main body, you have all the time in the world you need to cannulate the sleeves for connecting the bridging stent grafts to the brachiocephalic trunk and to the left common carotid artery, because there's unobstructed free flow through this window. So initially we will see here the reconfirmation that we are within the posterior tunnel hosting then the bridging stent graft to the brachiocephalic trunk. As we will see in a few seconds, here the bridging stent graft is being delivered and deployed, and the same maneuver is being carried out via the left common carotid, which you will see in a few seconds here with deployment of the second bridging stent graft via the left common carotid. And as said, the left subclavian still has to be revascularized in a classical fashion, either by an 8 mm Dacron graft or by transposition, according to the individual preference. And here, the completion angiography with regular patency of the supraortic branches and the CT scan showing a successful and complete exclusion of the lesion. So, we were lucky to collect a series of 43 patients in 8 centers where we combined our results. And this is a newly released article which you can already find online with a perioperative mortality of 9%, an acceptable disabling stroke rate, but a non-disabling stroke rate which is still too high, and every effort has to be taken to reduce this to a minimum. We then focused onto and as you can see here, the subgroup of remaining dissection after previous repair has the best results with regard to mortality and stroke. And if you remember the aortoscopy I shared with you at the very beginning, this becomes obvious because it's clear that patients with this very smooth intimal surface have a very low remaining risk of embolization because the underlying pathology is different and there is no substrate for detachment and for embolization. So these are the important messages. Outcome of the branched endovascular aortic arch repair is good. Disabling stroke is low, but non-disabling stroke is too high, and we need every measure for reduction. Best outcome in patients with remaining dissection after previous repair, but clearly more data are needed. So concluding, pathology determines the mode of treatment. This is eventually the most important message of this talk. The frozen elephant trunk technique has excellent results. Results of total endovascular aortic arch repair are promising. And finally, the creation of aortic centers with the entire armamentarium will aid in doing the right things in the right patients. Thank you.
Martin, thank you very much for that very nice talk. Very scary pictures. It's amazing we get patients through when they have that much atherosclerosis. Our next talk will be a very nice chat on an interesting cannulation technique for type A dissections.
Ladies and gentlemen, my name is Mohammed Salim from the University Hospital of Schleswig-Holstein, Campus Kiel, from the Department of the Cardiovascular Surgery. Thank you very much for this opportunity to share in the ISMIC. I would like today to introduce our experience with the transatrial cannulation of the left ventricle in cases of acute type A aortic dissection with about 230 patients since 2010. As you know, there is several techniques of cannulation in case of acute aortic dissection type A. The optimal method remain until now controversial. The most used aortic, or the most used technique, is the cannulation of the aorta, the right axillary artery, femoral artery, and since 2010 we used the transatrial cannulation of the left ventricle through the right upper pulmonary vein. We carried out a retrospective analysis with 235 patients with our cannulation technique since 2010 versus 185 patients with other cannulation technique before 2010. We tried to match both groups so that there is no significant difference regarding the clinical presentation and the preoperative risk factor. The patient with our technique, or the way we use our technique, are represented with more cardiac tamponade with about 21% versus 12% to the other group. The intraoperative course showed also no significant difference, only in the operation time and the blood transfusion. Otherwise, the cardiopulmonary time, the cross-clamping time, and circulatory arrest time were similar in both groups. The post-operative courses showed nearly no significant difference between both groups. The limitation for these studies and retrospective analysis It is a single center experience. The patient number are relatively small and there is several surgeons. Our conclusion found that this technique is safe to be used in patients with high risk groups. Thank you very much.
Welcome back, everyone. We can say that we had an excellent start to the ISMICS Reimagine 2021. The morning sessions of Cardiac Masters and Thoracic Masters were excellent. What do you think, Sam? What was the highlight of this session?
Gosh, Nirav, it's hard to say with all the great talks that we've heard in the last couple of scientific sessions. What intrigued me, if I could say more than others, was maybe the round-the-world expose of what the low-risk TAVR trials have done for aortic valve replacement around the world. We heard some great comments about how in the different parts of the world the things to think about are different, and then pushing the limits of TAVR in various aspects with 4 nice abstracts was also quite intriguing.
And also the talks about the aortic dissection and the arch stenting were also very innovative. Cannulating the aorta through the left atrium is a very unique concept. I think seems to be pretty feasible in hemodynamically unstable patients. How about you, Abbas? What did you think about thoracic track?
Well, Nirav, 2 excellent sessions. The first one really covered all aspects of minimally invasive approaches to lung resections, both standard and complex, including segmentectomy. And there was especially a great talk from Dr. Gilbert on surgery in the octogenarians. The second session, also outstanding, covered mediastinal disease. We saw how the minimally invasive approach to thymectomy is really important for diseases like myasthenia gravis.
If I could add, Nirav, the first session, I think we didn't mention too much about it, but it was a great session for valve-sparing root replacement done minimally invasively. And unfortunately, we had a technical issue there, but for anybody that's interested in going back, the online library is going to be a wealth of information about some of these techniques that are quite unique. I, for one, am planning to go back and look at those talks again.
I fully agree. I think those were excellent how to do it video done by exemplary faculty. These are master technicians, but the more important thing was what they were highlighting is step-by-step approach. We're dealing with minimally invasive aortic surgery of the proximal aorta surgery. We will be coming back again over here after a very short break, where we will hear from Dr. Thomas Grosky and the presidential address. Please join us back soon for the presidential address. See you later.
You may not hear, you may have your fears. Can you see the